Okay, thank you, Vipul. We are going to start with our transplant update today. We all know that one of the biggest advances in the field of medicine in the last century has been in the field of transplantation. And what started off as many experiments to perform transplants from one species to another, then from human to human, has now culminated in one of the most successful procedures for people with end-stage organ disease. Transplantation has become successful as a result of our understanding and progress in the field of immunology. It is essentially understanding how the immune system responds when a foreign organ is transplanted into the recipient's body, and our progress in having over a period of time several immunosuppressive drugs to curtail that immune response that has made transplantation a very successful form of treatment for those with end-stage organ disease. We thought we will take up this topic of transplant update, and we wanted to make it a very clinical update. And we have taken it up exactly in the way one would want the transplant to happen and be successful, and what to do when that transplant is immunologically or due to some reasons it is failing. Accordingly, we have planned out 8 topics, and this is how essentially the transplant has progressed. In the first part, we'll have Dr. Shruti Tapiawala, who is very passionate about transplant immunology, who is going to talk to us about immunology of transplant bench to bedside. So she will be telling us about the immunology and how to take it up in working up a patient for transplantation, and then immunologic monitoring of a transplant patient after transplant. Now, when you do a transplant, because it is the immune response which would determine whether your graft would be accepted or not, how intensively should you immunosuppress in the early period or at the time of transplant? And for that, we have Dr. Sankar Prasad, who will tell us about induction immunosuppression and how to decide on what induction immunosuppression in different cases. After the induction immunosuppression, it is important that rejection does not develop in the subsequent period, and therefore how to maintain the graft with maintenance immunosuppression, and I will be talking about this. In the last 2 decades, one new immunosuppressive drug in its category called as proliferation signal inhibitors has come, and it has certain specific advantages, and that has made a difference in certain cases, and that's sirolimus and everolimus. So Dr. Bahadur will talk to us about use of these drugs in kidney transplant patients. So these are the 4 topics that we will be having today. Tomorrow we'll have Dr. Vikas talk to us about use of transplant in different situations, use of maintenance immunosuppressive drugs in different situations. Then we'll have a presentation of pathology of acute and chronic rejection. We will then have a presentation on treatment of acute rejection, and finally a presentation on treatment of chronic allograft dysfunction. So We thought we are covering every aspect of transplant in this transplant update. With this brief introduction, I would now request Dr. Shruti to start with the presentation. Please upload your slides and let's move on with our transplant update. So over to you, Shruti.
Thank you, sir. I will try to do justice to the subject. I will try to keep to my time of 25 minutes, but I suspect 2-3 minutes up and down. As sir has rightly said, that we have advanced a lot in transplantation in terms of technology, in terms of medications, and that is where our outcomes are better than what they were in the last decade. As sir has rightly said, organ transplantation is a miracle of modern science. And I will today tell you a little bit about the immunology part of it. So when one organ is taken from someone's body and placed into another recipient for replacing a damaged or a missing organ, it is known as a transplant. The transplanted organ is known as a graft. And the organ transplantation is the greatest advance because now we do not have to live with failed organs. Now, what are the types of grafts? Now, these first few slides are basic. If students are attending, it will be good for them. Autograft, when there is a graft which is transplanted within the individual, example, a skin graft, which can be transplanted from one part to the other. Allograft, when a non-identical twin is giving an organ to another person but of the same species. Isograft is within the same species and between identical twins, so you have a similar tissue. And a xenograft is between species, like this. Recently we had heard that a biogenetically engineered pig was used to harvest a kidney to be given to a brain dead individual, and the experiment was successful for 72 hours. They had deleted a gene due to which rejection was happening from xenografts. So we have to see how successful that is in the future and whether we can use it. But as of now, we are not doing xenotransplants. We are doing allotransplants or isotransplants. The immune responses to the transplant tissue. This is very important. We should know what our body is reacting to so that we know what we are going to have to combat. So the transplant rejection is caused by the genetic differences between the donor and the recipient, HLA and the blood group antigens. These are the differences which the body sees when an allograft or a graft comes from someone else. Allo antigens are antigens which vary between the members of the same species. Allo reaction is an immune response to the allo antigen. Allo reactions in the transplantations would be host versus graft, that is a transplant rejection. Graft versus host, that is in the case of bone marrow transplant. So here I have shown this in this cartoon, that when a kidney is transplanted, the recipient T cells are attacking the transplant, that is a host versus graft. And when you have a graft versus host in case of a bone marrow, it is your graft which is attacking your body. What are the effectors of rejection? Major players are the T cells, the B cells, the antigen presenting cells, because we have cells which are going to process the antigen derived from the donor and presenting to our immune system. Major histocompatibility complex, which is MHC, and the most important part of the transplant reaction. T cells, we all know, arise from the thymus, from the bone marrow derived precursors. Each T cell has unique T cell receptor clone. Selection for positive or negative control. Subtypes: CD4 T cells, antigen specific immune response, CD8 T cells, precursors to CTL or class 1 MHC. B cells will arise from a mature in the bone marrow. There is a negative selection, express the B cell receptors on their surface, and when these are stimulated, the B cell will secrete antibodies of the same specificity as the B cell receptors. Antigen presenting cells, most important, they activate the T cells, endocytose the antigen and display it on the MHC molecules. The T cells will interact, recognize with the antigen on the MHC to become active. Now the HLA system. This is the most important, I would say, discovery of science, which was way back in 1940s. The genetic loci involved in the rejection of foreign organs is known as the major histocompatibility complex, and highly polymorphic cell surface molecules are encoded by the MHC. The MHC is called the HLA, which is the human leukocyte antigen system, because these antigens were first identified and characterized using alloantibodies against the leukocytes. So they went reverse. They tried to see what was reacting with the cells. Leukocyte agglutinating antibodies, leukoagglutinins, were observed in the serum from multiparous women and previously transfused patients. Graft rejection was found to be associated with the development of antibodies against the allogenic leukocytes. The HLA system has been well known as transplantation antigens, but the primary biological roles is in the regulation of the immune response. These exist on all the nucleated cells in the body. Class 1 has loci A, B, and C on all the cells, including T cells. Class 2, loci DR, DP, DQ on antigen-presenting cells, that is B cells, dendritic cells, but not the T cells. Its purpose is to present antigen in its groove to the T cells in order to generate an immune response, identify cell from null cell. Now, this is important because our system has to identify what is not ours, and that is the role of this. Now, why is it important to us? Because there have been multiple studies where it has been well documented that the better the match of these loci, the better will be the outcome, because your body will see lesser of mismatches. The body will see lesser of non-self when you have matched HLA loci which are going for transplantation as transplanted organs. So this is a well-known study where we have seen that when there is the best match, then your survival becomes best. And when you have the least of the match, the survival is poor. So HLA typing is the information required for matching, information required for future complications, example rejections, because if you know what is non-self, you can monitor what is happening against that non-self antigens, which I will come to again later. Information required to understand if the prospective transplant recipient has antibodies against the donor antigens before the transplant. So HLA typing is extremely important whenever we are considering a transplant. Now, this is an example more for students that how many matches. So what am I going to see? I'm going to see when the donor is giving to this recipient, what is going to be foreign for this recipient. So if you see A2, A32, the recipient has, and A24 homozygous, the donor has, because both the loci have the 24 antigens. So it is going to be a double dose of 24 antigen going to this recipient, and 24 is foreign. B35, B51 is matched. DR1, DR13, DR5 and 6 are going to be foreign. Now, if you reverse it, what is going to happen if the donor is this one? If the donor is A232, these are going to be foreign for the recipient. B35, 51 are anyways matched, and your DR1, DR13 are going to be mismatched. So it is always the perspective of the patient that you have to see what is coming in which is mismatched. So what are the reactions or the rejections which we expect? We expect acute cellular rejection, antibody-mediated rejection. Differences in the HLA antigens, mismatches are going to incite reactions as body recognizes non-self on the mismatched antigens from the donor. Cellular rejection, now the rejection part is going to be covered very much in detail tomorrow by Dr. Prashant Rajput, but I am just touching it and leaving it. Caused by T-cell mediated reaction, destruction of the graft occurs by CD8 and CD4 helper cells. Pathways are direct and indirect pathways. Antibody-mediated rejections, there can be hyperacute, there can be presence of preformed donor-specific antibodies against the HLA antigens of the donor. Acute rejections, initial exposure to the class 1 and class 2 antigens. Antibodies cause an injury by complement-dependent cytotoxicity. They cause inflammation and they cause antibody-dependent cell-mediated cytotoxicity. So it has been long recognized that these antibodies reacting with the HLA antigens on the renal allografts are known as donor-specific antibodies, and they will induce reactions, rejections in various manners. These develop usually when you are exposed to these haloantigens through blood transfusions, pregnancies, previous transplants. So any tissue coming from outside to you is going to incite antigen response, and that is going to make antibodies. What are the types of antibodies? from prototype that we are seeing historic. So pre-transplant, you want to see whether the patient had any antibodies before the transplant. So time 0 is the transplant. Before that, historic antibodies means that the serum had some antibodies in the past and are not seen in the system now, so they are in the memory. Current means that there are circulating antibodies in the system presently. So what is there presently is immediately going to attack. What is there in memory will come later on. After the transplant, I am looking at de novo antibodies. So you did not have any antibodies in this recipient beforehand, neither historic nor current, but post-transplant, because the allograft is a foreign body inside, it is being recognized by our immune system. And if the immunosuppression is lesser than what is required, antibody formation is going to happen. And as the antibodies form, they will call the damage. Why are these important? It is very well known that they lead to antibody-mediated acute and hyperacute rejections, chronic rejections, and long-term dysfunctions in the heart, in the lungs, and in the kidneys, and in the allografts, whichever possible. This was very well thought of by Dr. Terasaki in 1969 when he released a paper where he demonstrated that HLA antibodies are deleterious. He called them toxins because that time he did not have the word antibodies. He said there were some toxins which were circulating in the body which are attacking the graft. If you have a second allograft, you have even more cytotoxins and the life of the allograft was shorter. So this was first recognized long back, and then multiple levels of work have been done on this. Recently, there are papers which are showing that pre-existing donor-specific HLA antibodies predict outcome in kidney transplantation. So if you have anti-HLA DSA, which is positive, DSA means donor-specific antibodies identified against the donor. If you have class 1, if you have class 2, you have an inferior survival as compared to when you do not have DSAs. If you look at the graph A, you will see that if you do not have any anti-HLA antibodies, you do the best. If you have HLA antibodies and they are against the donor, you do the next best, but still inferior. If you have HLA antibodies, but they are against the donor, you do very inferior to the above two groups. So having HLA antibodies itself predicts a poor outcome of any allograft coming inside our system. If you have an antibody-mediated rejection along with the presence of donor-specific antibodies, then your outcome is inferior as compared to when those antibodies have not incited any reaction as yet. So overall, the result is that DSA positive, inferior outcome, DSA negative, superior outcome. Now, these are the stages of humoral alloreactivity which have been understood over years. So you have a circulating antibody, you will have a C4D deposition. This stage is very important. You will have a circulating antibody, but it might be accommodating in the body. So your body is trying to accommodate that response and not allow tissue damage to happen. There is some amount of complement deposition and activation which is happening, but it is not damaging the tissue as yet. So this can be counted as a pre-rejection versus an accommodation, because this is the stage 2 which is going to tell us what is going to happen next. So in this stage, if your body accommodates it, accepts it, it will not cause a reaction. If the body is reacting to it and it allows the tissue injury to happen, and the subclavicle humoral rejection will start and the tissue injury will start. So you and me, whenever as clinicians, we see a creatinine or we see a cardiac dysfunction or we see a lung dysfunction or we see a rash on a vascular composite allotransplant, it is a tissue injury which we have seen. So that is the last stage when you see a dysfunction. So what we see is this red part, stage 4. But there are 4 stages before this where we have to be alert ourselves. So this is another way of looking at it, that you have preformed DSAs, you have complement activation, you have an indolent AMR, and then you have a graft dysfunction. So I would say, and the whole world is looking at this, that we have to stop it here so that we don't allow the tissue damage to happen. So what do we need? We need to identify these antibodies. We need to have ability to monitor them post-transplant. prevent the graft damage, be able to transplant sensitized patients with optimal outcomes, identify very low risk patients so that you don't have to over immunosuppress them and cause infections. So an HLA lab or the technology available is equal to risk assessment for you today. A pre-transplant patient, a pre-transplant situation, you have to assess what is the risk between a donor and the recipient, and what does that mean? It is the HLA typing, because you're going to see the amount of mismatches. What is the risk of not finding a donor is the amount of antibodies present in the patient. So there might be clinicians attending where you might be having patients who have multiple antibodies and you're not able to find a donor only for them. So that is a risk assessment. Single donor risk. So what is the risk with that particular donor is the cross matching. That you will know that, okay, with this donor, what is the risk? Cross match tells you what is the risk, whether there's going to be a rejection immediately, yes or no. And early graft loss is what this tells us. Post-transplant, we recognize new risks. So the lab helps you recognize what are the risks. So you are going to be able to find out if there is going to be a memory response. Say if you had a patient who had antibodies before, say 2 years back, 3 years back, the serum was showing antibodies, but now it doesn't have. But historically, the patient has. So the lab is supposed to tell you that there is going to be a memory response with this donor. Be careful. It is going to help you guide treatments. It is going to help you whether your desensitization is working, whether your rejection treatment is working, whether your patient is developing de novo antibodies. And this is very important because technology is helping you pick this up earlier than the tissue injury is going to happen. So like I told you, the risk of pre-transplant is always done by typing. So I cannot enough emphasize that please do complete typing of A, B, C, DR, DP, DQ, because they are equally important and the magnitude of difference is important. Lesser the difference, the better. Previously, only A, B, DR were recommended, but now there is enough literature to tell you that DP and DQ and C are enough antigenic to give you chronic allograft dysfunctions. How do you identify antibodies? Cross-matching and panel reactive antibodies. So cross-matching is going to tell me if there's immediate risk to allograft loss, and panel reactive antibodies is going to tell me that whether there are some circulating antibodies and which are those antibodies. So cross-matching was developed in attempt to identify the recipients who are likely to develop acute vascular rejection of a graft from a given donor. And the phenomenon of acute hyperacute rejection is a result of preformed antibodies because of donor-specific antibodies in the recipient. And it can happen immediately on reperfusion, and you may have to remove the allograft. So this was a landmark paper where Dr. Terasaki very elegantly showed that if you have a positive cross-match before going for the transplant, you have 80% chance of losing the allograft. If you do not have, if you have a negative cross-match, you have 15% of losing the allograft. And recipient without antibodies, HLA antibodies, 2.4%. So the survival also was equal. So if you have a positive cross-match, recipients with anti-HLA antibodies, then you have a survival of 10%. More than 3 months is only 10%. So imagine this was a landmark paper which told everyone, and it still persists, that if you have a positive cross-match, you are contraindicated to go for transplantation. As time has advanced, as technology has advanced, there have been delicate dissections of the cross-matches to identify what is a false cross-match positive, what is a false negative cross-match. So that I will get to it a little later. Now, what does the CDC cross-match do? A complement-dependent cytotoxicity cross-match. It is simply putting the lymphocytes of the donor into the recipient serum, adding complement, creating a milieu of the body, and an experimental transplant in the lab. If the cell is killed, you know that this is a positive cross-match. And the percentage of kill is what tells us how much is the strength of the antibody. This is as simple as a crude CDC cross-match. The sensitivity keeps increasing as we add nuances to it. Now let us look at a case. 43-year-old male, remote blood transfusion, 4 antigen mismatch, deceased donor, 1 DR, 1A match. Current and historical PRA by a CDC was 0%. Now this is an old case, hence it is a PRA by CDC. CDC cross-match was negative, thought to be a low risk, taken for transplant. Within 24 hours, the graft had to be removed because there was a hyperacute rejection and there was a there was a loss of the allograft. So the drawbacks of a CDC have been recognized over time that not all lymphocytotoxic alloantibodies that cause a positive cross-match are specific to donor antigens 1, so there can be false positivity. Some antibodies display autoreactivity causing lysis of the own cells. So auto cross-match is very important to delete that part. So this becomes a false positive. Now here there was a negative cross-match and we lost the allograft. Why can that happen? Because if you have a very low antibody level in the system, which is against the donor, it can easily get stimulated and within 24 hours rise to levels which can cause rejection. And that is what happened over here. Hence, identifying this beforehand will help us identify a false negative CDC cross-match. Now, there have been attempts to increase the sensitivity of this cross-match because if there are lower antibody titers, how do you pick it up on a cross-match? So they added an anti-human globulin layer to it, which increases the sensitivity of the cross-match of CDC cross-match to 3 to 4 times. So where a NIH CDC cross-match is positive only to 1 in 2 dilutions, there an AHG CDC cross-match will be positive in 1 in 32 dilutions. So that means it becomes a little more sensitive in picking up lower titer antibodies, but still not very low. Then came the flow cross-match. Now the float cytometric cross-match is the most sensitive cross-match available to date because it is trying to not pick up IgM antibodies which are not relevant to transplantation. It will pick up only IgG HLA antibodies. Now what happens here is same thing, serum and the donor lymphocytes are incubated together, anti-IgG FIT-C is added, and then a color chrome is added and run through the spectrophotometer or a flow cytometer, and the reaction is measured in terms of mean channel shifts or median channel shifts. And this is a very sensitive form of cross-match because it picks up even very low titer antibodies up to 5,000 MFIs. So this is the comparison for clinicians to understand that AHG CDC cross-match, the normal cross-match, the AHG CDC cross-match and the flow cross-match. So you see 1 in 64 dilutions of a serum can be also positive. So a lower titer of antibodies is also picked up by flow cross-match. So I would say in today's date, if your flow cross-match is negative, then you might as well go for the transplant. But if you have DSAs in lower titers, you have to be careful of rejections later on in the period of transplant and not immediately. Now, what happened to this case? So the CDC was negative. Then a retrospective flow was done, which turned out to be positive, which meant that this might have been low titer antibodies. So can we validate that this flow was really positive? Was there really a donor specific antibody, or we can just presume it? So now you have solid phase assays which are going to identify HLA antibodies, differentiate it that these are only IgG class of antibodies which are relevant to transplantation. They are not in the serum where there can be a jumble up of a lot of antigens. These are factory made cells, factory made beads where the cell culture lines are coated and we are identifying antibodies. They can reliably determine the specificity. It will avoid immunologically high-risk transplants. It will help finding appropriate donors who do not have those antigens. No complement activation is required in this. Hence, you're not dependent on the system of the body, which can be a flaw in this because if they are not activating antibodies, they may not be relevant, but we are not sure at present. There are kits which are available, but we are still not sure. These can detect very low level antibodies. So you can be alert for a patient in future that, okay, they had donor specific antibodies which are very low and I have to monitor. So what are these? Just in a little bit of a detail. So PRA is a word which we use very commonly. It is panel reactive antibody, a measure of antibodies in the patient against a panel of antigens from multiple donor cells from a population, as opposed to a specific donor, which is a cross-match. When you are cross-matching with a single donor, that is just 1:1. When you have a panel reactive antibody, it is a panel with the population which you are testing against. It gauges the immune activity of a patient. So if your PRA is 80%, that means your patient is reacting to 80% of the population in your community. These have to be monitored 3 to 6 monthly to identify the presence of HLA antibodies because these wax and wane. They don't remain constant. So if at all today you have an A4 antigen or an A24 antigen, after 1 year, you may not find it circulating in the system. You cannot say chala gaya. It is there in the memory. Suppose you give an A24 organ, somewhere down the line, the memory will bring it back. So you have to have a cumulative list of antibody rather than a single snapshot. So these are the differences between the antigen beads which we have. So one is a screening bead, which is the cheapest kind of test which we have, but a very robust test. So a screening bead means that an inert bead has been coated with class 1 multiple antigens, and you're running the serum along with it, and you want to see what are the whether the beads are reacting to the serum or not. So you will get a yes or no. It is a qualitative assay. You will get a class 1, yes or no, class 2, yes or no, MICA, which is minor histocompatibility antigens, yes or no. That's it. If you don't get a yes and it is a no, forget about it. You don't have antibodies or HLA antibodies in the system. But if you have, say the class 1 spikes yes, then you find out what are those. So then you go for a single antigen. So then in a single antigen, you have a bead which is coated only with a single antigen number. So A2, the bead will have only A2. It is a mix of beads which has a single antigen coated on every bead. And you then have to see which beads are reacting, and you write out that, okay, this patient has these specificity beads reacting. So the patient has HLA antibodies to XYZ specificities. So this is how a run sheet looks like, that you can get graphs and you can get MFIs where you can take a cutoff that, okay, more than 1,000 I will call positive, and you will say weak, moderate, strong. So that is how we usually tell how much is the MFI. See over here, B45, you can see a mean fluorescent intensity of 12,000, then B76. So we can tell you the MFIs as to how much is the strength of the antibody, what is the antibody, what antigen it is against, and what allele it is against. So you are very specific. So now if you see the sensitivity of DSA identification methods, so you will see that the DSA levels, when you try to see, you will see low to moderate sensitivity of all these technologies. Now case 1, final analysis. So we saw that the CDC was negative, but it was false negative because there were low titer antibodies with a flow cross match picked up. Retrospective PRA, there was a 5% class 1 HLA antibody. HLA mismatched antigens were A23, B37, B53, DR103, and the identification was A23, which was there on the donor. So now you see the HLA typing was very important. So whether it is a deceased donor or it is a living donor, HLA typing of every donor is important. Because otherwise later on you do not know how to identify whether this is donor specific or what it is. So we had a DSA which was in a very low titer which caused the graft loss. So this is a clinical paradigm which we have, that if you have, so the immune threshold is moving. So initially it was that a cross-match negative transplant was contraindicated. Now you have that, okay, if you have a CDC positive, a flow positive, you have a PRA or a virtual cross-match positive, then you can take it as a contraindication, but you may be able to do a desensitization or an acceptable mismatch, which can be done and transplant can be done. If you have a negative cross-match, but low titer DSAs, then you have to consider it. You have to observe the patient, understand that it might be a false negative, and all this addition of technologies together helps you take this ahead. Now, the last part is post-transplant monitoring, just 2 or 3 minutes more. So, there is a concept of de novo antibodies. You had a clean patient who had no antibodies whatsoever, no sensitization events like blood transfusion, pregnancies, previous transplants whatsoever. But once you transplant, there's a 15% chance of low risk transplant patients at a mean time of 4.6 plus minus 3 years post transplant to develop de novo antibodies. De novo means newly developed antibodies after transplantation. These are more likely to have preceding clinical and subclinical cellular rejections in 0 to 6 months post-transplant period. So if you have patients who have had acute cellular rejection in the first part of the transplant, do monitor them for de novo antibodies because there was an incitation, a reaction which had happened. In those who develop graft dysfunction, the de novo DSA typically arises before the onset of proteinuria or rise in creatinine. So a tissue injury happens, but before that, the antibody surge has happened. So it's better to monitor these antibodies, monitor for anything new which is forming to prevent a tissue injury in the future. This also helps you to tailor your immunosuppression. Because many of us, when we are seeing patients, what do? Okay, 5 saal ho gaye, let me lower the immunosuppression. But it is always wise to monitor the antibodies. You do a PRA. If it is negative, go ahead, reduce it a little bit, keep monitoring the PRA. The moment something comes up, back up. And there are enough studies to show that de novo DSAs are detrimental to the graft. If you have graft losses with other causes, they are much lesser than what happens with antibody mediated. Class 2 is like a case of a post-transplant or a pre-transplant antibody which was present in low titers and it caused a damage. So there is this patient who had a DR07 antibody in a very low titer pre-transplant. It was monitored post-transplant. The DSA remained present at low titers for 3 years post-transplant. At 3 years post-transplant, there was proteinuria. There was a creat which was still at 1.4, but the biopsy showed advanced transplant glomerulopathy and the renal function slowly deteriorated. So even a low titer can cause a damage. So we have to be very careful that if you know beforehand there is a very low titer DSA, either you do an acceptable mismatch transplant or you keep a watch on the antibodies and keep your immunosuppression to the level that it doesn't react. TG is frequently associated with class 2 antibodies, more to DP, DQ, and DR is what is seen in literature. And this is how a TG looks. Tomorrow we are going to talk about chronic allograft dysfunctions, but C4Ds are positive. There can be multi-layering of the GBMs and you will find a rapid fall down of the graft. This was an elegant multi-center study where they found that most of the patients are developing alloantibodies at between 3 to 5 years post-transplant, and it is very good to monitor. And if people have developed these antibodies, then all patients who developed antibodies, they persisted for a period of 6 months to 8 years before the kidney was rejected.
Can we summarize?
Yes, we are just summarizing. Last 2 slides now. So take home points. Mismatched HLA antigens act as potential stimulus for rejections. Typing defines the magnitude of the potential stimulus. Accurate typing is imperative for patients who already have HLA antibodies. Molecular typing is recommended. CDC crossmatch defines the risk of hyperacute rejection. Flow crossmatch defines early immune complications. Crossmatch should always be interpreted with antibody screening data. Lab is equal to risk assessment for every patient. And the last slide, antibody screening, PRA, pre-transplant and identification if screening is positive always helps. Tailor the immunosuppression, choose a suitable donor against whom the patient does not have antibodies, and a screening and monitoring post-transplant will help you identify the appearance of de novo DSAs and monitoring pre-transplant DSAs. I will end there.
Thank you, Shruti. Can we stop slide sharing? So that was an excellent presentation, Shruti, and a very practical presentation of evaluating a patient for transplant and monitoring the patient after transplant. And for benefit of all those who are attending this today's program, I must tell you that we have been running an advanced transplant immunology lab, which is essentially handled by Shruti. And we do practically everything that she spoke about today, right from evaluation of the transplant patient to post-transplant monitoring. And we will have at one point in time a presentation of series of cases where we will show how this evaluation and monitoring has had an impact in the outcome of transplant patients. Shruti, you want to make some comment to this?
No, sir, I agree with you that, all the detailed evaluation, which is practically possible now, it is not only on papers, it is possible and it is helping us. In fact, whenever we do this series, we are going to present the practical experience which we have. say I presented a case series of 100 cross matches we did around our lab, and we found that at least 11% had PRA positive who had DSAs, and there were 6% CDC cross matches which were false negative. So it helped that identify people who are at high risk and prevented them from going to transplant with that donor. So it is practically very possible to minimize the risk of rejections with all the technology available today, which is easily accessible now.
So a very important message is that flow cross-match should always be done in every case to assess the risk of developing immunologic complication after transplant, and even PRA, because looking for PRA, screening PRA is not very expensive, and it gives you an idea about how sensitized or what is the immune activity of the potential recipient. So we will have some more questions, Shruti, in our panel discussion at the end of today's talks. Let us move on to the next talk today, that how do we give intense immunosuppression at the time of transplant, and that's called as induction immunosuppression. And for that, I would request Dr. Shankar Prasad to load his presentation, and over to you, Dr. Shankar.
Yeah, good evening, sir, and thank you for this opportunity. I thank Sir Narmada Kidney Foundation and Novartis for this wonderful opportunity to be part of this transplant update. So my talk is on the induction immunosuppression in kidney transplant. Can you see my?
No, we cannot see your slide. You will have to load them.
Just a minute, sir.
Yes. We can see now.
Yes, sir.
Perfect.
Yeah. So in my talk, I will be talking about the available induction agents and briefly on the newer molecules which are in the pipeline, and how we should strategize the patient into low risk and high risk stratification, and which induction agents to choose and when, what is the present guidelines say, and what in our Indian scenario, and few special situations. As we all know, in the last 5 decades, a lot of drugs have come, and there is a great advancement in the care of transplant patients as far as the therapeutic strategies are concerned, starting from induction agents to the maintenance agents, you can see in this figure. So what's our ultimate aim is for a better patient and a graft survival rates. Well, why you need an induction agent in a transplant scenario? So we need to reduce the acute rejection. And the second important thing is it gives you a chance to play around with the other components of immunosuppression regimen. Like you can minimize the steroids, or you can switch to everolimus, or you can say steroid avoidance, or you can make the CNIs minimization. So you have a chance where if you use a good induction agent, you can play around with the immunosuppression regimen for your maintenance phase. Well, the long-term goal is to improve the long-term graft function as well as the patient survival. The induction agents can be classified based on the clonality or whether their ability to remove the lymphocytes from the body. From the clonality point of view, we divide them in monoclonal and polyclonal. As far as the lymphocyte removal wise, we classify them as depleting agents and non-depleting agents. Well, coming to the common induction agent that we use, that is the Il2 receptor antagonists. They are the one which is monoclonal one, and they are non-depleting agents. We have 2 drugs in the Il2 receptor antagonists, that is the Basiliximab and Dacluzimab. Dacluzimab was there, and it has since 2009 it's not in use, means it is removed from the induction agent protocols. Well, we have Basiliximab, which is still used, and it's a chimeric antibody. Well, the good thing about Basiliximab is even at the smallest concentration, like more than 0.2 microgram ml is required, so that it can saturate the anti-CD25 antigens on the T cells. So we give Basiliximab, as you all know, in 2 doses. One is on day 0, another one is day 4 post-transplant. If you look at the IL2 receptors, there are three types of receptors. One is alpha, beta, and the gamma, among which alpha is the CD25. One thing I want to emphasize here is when the T cell is under rest, only beta gamma will be expressed. When T cell get activated, that is the CD25 expression will come, so that at this juncture, if you give an IL2 receptor antagonist, they act only on the activated T cells. What I want to specify is they are very specific, so that they act only on the activated T cells in our body. So the Rituximab, which is the available IL2 receptor antagonist, we have many studies from the last 3 decades. When we compare to placebo, it has proved beyond doubt that it is a good induction agent, especially in the scenario when the cyclosporin was used, azathioprine was used, and the steroids were used in the previous decades. Well, when it comes to the rejection episodes, yes, when it compared to no induction, Rituximab sure prevents the rejection episodes, especially the acute rejection episodes. When it comes to the long-term graft survival and the patient survival, there are studies which favors Rituximab, and there are studies in this TAC era that the Rituximab may not be even necessary. The most important thing in IL-2 is, unlike ATGs, it is well tolerated. You don't worry about any risk of infusion-related reaction. It can be given like in bolus doses, and there is no risk of malignancy, infection, or other side effects. So that is the most advantage of Rituximab in our practice. Coming to the other, that is what is available is the Anti-Thymoglobaline, that is ATG. This is a depleting agent and it's a polyclonal in nature. Well, how it is prepared? We immunize the animals with the human lymphoid tissue. There are 2 types of the animals which are being used. One is the rabbits, where there are 2 types of ATG are available. One is ATG Zenzyme, another one is ATG Fresenius. By horse, we can develop AdGam. So how this ATG acts? Basically, they are polyclonal. So they act on lot of antigens present on the T cells. You take CD2, 3, 4, 8, 16, 25. So they act on multiple antigens on the cells. And what they do, they deplete them. And both from the circulating T cells as well as from the lymphoid tissue. So what's the problem with the thymoglobulins we should remember is cytokine release syndrome. So always we should have in our mind they can cause infusion reactions. And when you are giving ATG, we should be very careful. We should always give the patient with pre-treatment with steroids and acetaminophen and anti-allergic drugs. Well, during infusion, we should always monitor the vitals of the patient. Common adverse effects, yes, serum sickness, illness can occur. Bone marrow suppression, leukopenia, and thrombocytopenia. Well, the most important adverse effect is there will be a risk of infection and malignancy when we follow up the patient on a long term. Types of ATG, if you look at, as far as the research wise, there are 5 types. When in the practice, the clinical practice wise, we have 3 molecules. One is the Zenzyme thymocyte, that is again rabbit, IgG. Then Fresenius one, that is from the Zurkard cell line, that is also from the rabbit. And from the horse, we have AdGam molecule, which can both IgG and IgM. Well, if you look at the difference between the rabbit ATGs, that is the Graflan, that is the ATG Fresenius, and the anti-thymoglobulin, that is from the Zenzyme. Well, this is from the thymocytes, that is from the donors, from the patients, that is the primary human cells we use, the thymocytes, whereas in the Graflan, it is against the Zurkard cell lines. From the Zurkard cell lines, they produce this. The final molecule will be like more of in the infusion, like it's an 100 mg and 200 mg vial will be available, whereas the Zenzyme ATG is available as powder in 25 mg per vial. The most important difference as far as theory is concerned is the Graflan, it is have an effective only on selectively for activated T cell. That's what they claim. Whereas thymoglobulin purely depletes all T cell lines. Of course, B cell will be depleted by both the molecules. When it comes to the adverse effects, the side effect wise, the CMV disease, other infections, lymphoma, and PTLD, the Graflan has an added advantage that there's a lesser incidence. That's what the claim from the Graflan. There is no head-to-head comparison between Graflan and thymoglobulin in the literature. Well, coming to the dose, how we prescribe these drugs. When it comes to the Zenzyme ATG, 1 to 1.5 milligram per kg per day. The range varies from 1 to 4. It is given over a period of 5 days, and the maximum dose 6 to 8 milligram per kg. It should be given infusion wise in a central vein or with a fistula if the patient has through fistula vein. When it comes to ATG Fresenius, the dose is higher, 9 to 15 milligram per kg given over 1 to 4 days. ADGAM 10 to 30 milligram per kg IV over 5 to 7 days. Well, actually in practice, what is happening in the last 1 decade, like now the people have started using, even in the high risk patient, the thymoglobulin dose a bit less. If you take from the recent literature, up to 1 to 3 milligram per kg also people use in 1 through 2 days, and they rarely use up to 6 mg per kg even in high risk patients. When it comes to ATG Fresenius, the dose they are limiting between 6 to 9 milligram per kg and not going beyond that. In low risk patients also now thymo is being used, and sometimes they use a single dose of 1 to 1.5 milligram per kg. If you are using ATG Fresenius, you can use up to 3 milligram per kg. Well, actual common uses for these depleting antibodies, as you all know, it prevents DGF, especially when patient has a DGF, you can switch them to thymoglobulin. And another one important thing we should remember is it should be given intraoperative. Before the opening of the clamps, we should give, because it reduces the ischemia reperfusion injury. The another important thing is when we want to introduce CNIs late, especially when the patient has DGF requiring dialysis, these depleting antibodies will come into use. Then the most important thing is desensitization of highly sensitized recipients like retransplant, flow cross-match positive recipients. The depleting antibodies are preferred. Well, as I told, when we want to attempt to reduction in the maintenance therapy like early steroid withdrawal, CNI minimization, mTOR inhibitor switch, the depleting antibodies are the preferred one. And rarely we can use them, like the other uses are tolerance inducing regimens, rescue of the steroid resistant rejection, and the graft versus host disease. Well, in clinical practice, which ATG I should use? Like we have 3 molecules. If you look at the data wise, evidence wise, the ADGAM comparison with the ATG enzyme, like this is a study in 1999 itself, and it showed that rabbit ATG is preferable compared to ADGAM as far as the graft survival, rejection, as well as the long-term survival is concerned. So among this, next comes whether to prefer rabbit ATG, that is enzyme versus Fresenius. Well, there are no head-to-head control studies. Like the studies are there where they use rabbit ATG enzyme with that of Campath or with the Basiliximab, and ATG Fresenius with Alemtizumab and the Basiliximab. So the recent study in that is a meta-analysis done. They clubbed all the studies and tried to compare what is the advantage among these two. Well, the final thing they found is ATG Fresenius has some lesser as far as the infection adverse effect is concerned, that CMV and other viral infections are less, whereas when it comes to efficiency, the rabbit ATG enzyme is and the ATG Fresenius are similar. So what I want to say is, now you don't have much evidence to say this is better or this is better. You can use as far as your center choice and your experience. Well, it comes to ADGAM, it should be used only when you think the patient is not much affordable. Coming to the other molecules, well, Alemtizumab is the monoclonal depleting agent. It is again anti-CD52 monoclonal antibody on the T lymphocytes and B lymphocytes. It depletes both B and T lymphocytes. The adverse effect profile is almost similar to that of thymoglobulin. It is given as a single dose, 30 milligram dose, but though it has come in 2001, it is not into practice because it is basically used for multiple sclerosis, and now there is a black box warning for increased strokes and also increased infection in those patients. Currently, it is available for the distribution only in US. It is not available in any other countries. So I think that this molecule will come only probably in the next 1 or 2 decades, or it may not be useful as an induction agent at present. Well, as far as the evidence is concerned, there are 2 studies. One is INTACT study and 3C study. In both the studies, it is clear that it is on par with that of a ATG. Whereas when it comes to low risk individuals, it is preferable to Basiliximab. But again, the infection rate and was significantly higher with that of Alemtizumab. This is a meta-analysis which clearly shows biopsy-proven antibody rejection, biopsy-proven acute rejections were less with Alemtizumab compared to Il2 receptor antagonists, but not with that of the ATG. Well, the other outcomes are similar and infection rate was high with Alemtizumab. Coming to the Rituximab, as we all know, it's anti-CD20. Well, there are a lot of, not much literature. There are only 2 RCTs were there and about 19 observational and retrospective studies were there. So in this, finally, what I want to say is, at present as an induction agent, Rituximab is not used for either for low or high risk. Only it is useful now in ABO incompatible transplant and in our desensitization protocols. The dose used varies from trial to trial, from 375 milligram per meter square 2 dose, or 500 milligram, or 200 or 100 mg, depending upon the center's choice. Well, other newer induction agents we should know is Eculizumab. Well, it's Bortezomib and Eculizumab. Now they are rescue agents, basically used in severe rejections. But Eculizumab is useful in, especially in atypical HUS patient, where we are going ahead with the transplantation. Bortezomib now basically rescue therapy, and now some trials have been conducted to use as an induction agent. When it comes to other drugs in pipeline, humanized OKT3 is there, Enlimumab is there, and there are cells like Rituximab. Many anti-CD20 cell directed therapies have been under research, and then targeting other than IL-2, like we are IL-6 inhibition, 17, and IL-1 inhibition. Well, the most promising what I found is the IgG endopeptidase. As you all know, in 2019, this was found out. It's basically useful in highly sensitized patient undergoing transplantation. How it is derived? It is derived from the Streptococcus pyogenes. How it acts? It breaks almost all immunoglobulins in the body. So it makes a patient who is CDC positive or ADCC positive within 1 to 6 hours completely negative. So where it is useful, there are two small number of patients done in Sweden and United States, especially when you have a patient who is have high PRA and you want to do him with a cadaver transplant, because otherwise when CDC becomes positive, we can't desensitize him, and we can't wait for him for the graft to receive. In this scenario, I feel this molecule may make a lot of change. Here they are used with HARS ATG. Here it has been used with Alemtizumab. Here the advantage is you need not need plasmapheresis. We can go directly by using IDs, so that if you see this graph, within 6 hours, the HLA antibody titers from 25,000 MFI can come down to almost nil. Even C1q binding and HLA antibody levels within 1 hour, it will come to almost nil. So it looks promising. So now coming to the next part of my talk, it's like how to categorize the patient into high risk and low risk. As we all know, from low risk to high risk, if you say, we can decide on no induction, Rituximab, or Thymoglobulin. Well, no induction at present, we say identical twins, or in the era of TAC and MMF, even in low risk patient, we can consider no induction. What are all the low risk patients we have? Zero HLA mismatch. You can see in this slide, live donors, first transplant, especially if there is no DSA and no PRA, and Caucasian ethnicity and blood group compatibility, and if the patient has immediate graft function, they are all the category where we can use Rituximab or think about no induction. When it comes to high risk category, where we use depleting agents, when there is an increased HLA mismatch, some centers say more than 3, some will have more than 4. Then African-American ethnicity, when they have high PRA or presence of DSA, they are considered to be high risk and we should use depleting agents. Blood group incompatibility, if the patient has DGF, and if cold ischemia time is more than 24 hours or second transplant, these are all the patients whom we consider as high risk. Well, in Indian scenario, the other two important we should think always is the economic status, especially in low socioeconomic patients. They are very prone for infections. At that time, we have to decide induction regimen based on the individual. Then previous infection, having a previous hepatitis C or HIV, that also will play a major role in deciding the induction regimen. There's a good article in 2016 where they do the immunological risk assessment. Just I want to share these tables. See, few things are changing. Like previously we say previous transfusion is very important, where we'll think as high risk. Now with, as Shruti madam also told you, we have facility to see what is their immunological responder, whether it's a low immunological responder. If no PRA, no DSA, we need not bombard with Thymo. We can just go ahead with the Rituximab. Similarly, in previous transplantation patient also, though we consider Thymo is preferable, yes, if there is no DSA, still we can, depending on the patient, other profiles, we can decide which induction agents to be used. Then in this table, I want to concentrate the more importance nowadays we are giving for the DSA and PRA, where we prefer to use a Thymoglobulin instead of the Rituximab. When it comes to the CMV disease or hepatitis C, nowadays we have good treatment also, and we can give CMV prophylaxis. Nowadays, the importance is coming less as far as the considering them as high risk or low risk. But look at the guidelines. So we have KDIGO and CARI guidelines, and both, if you look at, have been there in 2009 and 12. What they say as far as induction therapy is concerned, they say that Il2 receptor antagonist be the first line of induction therapy, basically on a one single meta-analysis and one RCT where they compared Il2 versus Thymo for the induction. Then they suggest using a lymphocyte depleting agent than Il2 for any high immunological risk patient. That's the recommendation is 2B. Well, if you look at the practice wise, especially in US, the use of tacrolimus is high. In our practice, MMF has become high. Now steroid is coming down. And if you look at the depleting agent wise, T-cell depleting agents is still used high. Of course, there are many high risk transplants everybody is doing across the world. And Il2 receptor is still in the limelight, especially in US, its use is becoming less. Even in low risk, they prefer low dose Thymo. Whereas in other Western countries, still Il2 receptor antagonists are useful in low risk patients. Well, is the time to guideline to reassess? Well, if a guideline is not changed, there will be two things. One is either there is not much advancement as well as the literature is concerned. Another one is there is not much change in the thing. But if you look at the era of this, in the last 1 decade, almost every center has switched to TAC, MMF and steroids. So what the doubt we have in low risk, whether really Basiliximab is needed when you are using strong immunosuppression, especially tacrolimus and mycophenolate along with the steroids. Well, can we replace Basiliximab with low dose ATG? Some centers use 1 milligram, some will use 3 milligram, whether that may be preferable to Basiliximab. But on the other side, in the high risk group, whether to use Zenzyme or Fresenius, as already told, no head-to-head comparison, so anything can be used. Well, the use of high dose, initially it started out with 6 to 10 milligram. Nowadays, people have come to 6. Now, people are even reducing the Thymo dose. Whether it's really needed is the question, especially in the moderate risk patient. Instead of Thymo, when we think there is a risk of infection, can we use Basiliximab? These are all the questions at present. So just I will go through few slides about what made this question, like why these doubts have come up in the last 1 decade. This is in live donor kidney. This is a study, it's a retrospective study. They analyze for with or without steroid maintenance. If you look at the conclusion, no induction therapy is equivalent to Il2 receptor induction, whereas Thymo is preferable to Il2 receptor in steroid avoidance. If you are planning a steroid avoidance protocol, sure, Thymo had an edge over the Il2 receptor antagonists. Again, it's a retrospective study, but the population was very huge. It's a 2016 published. Again, it's a comparison in deceased donors. What's the conclusion they made? Again, in low risk, no induction, almost similar outcome with that of the Il2 receptor. This is basically TAC, MPA, and steroids. Again, if you are planning a steroid avoidance, well, ATG had a upper edge compared to that of the Il2 receptor antagonists. Well, if you look at this meta-analysis where they compared Il2 receptor induction in standard risk renal transplant, there are a lot of retrospective and prospective studies. No RCTs were there. Again, it shows that no induction is almost equal to Il2 receptor antibody induction therapy in standard risk renal transplant recipients. Well, this is the study for the low dose Thymo versus Basiliximab induction therapy in low risk. Again, it showed low dose Thymo is equivalent to that of Basiliximab. This is the another study, similarly same for the low dose rapid Thymoglobulin versus Basiliximab. The conclusion is it is similar and adverse effects were less when you use a low dose Thymoglobulin. It's an Indian study, single dose Thymoglobulin. They have tried in their transplant patients and they found that even single dose Thymoglobulin is useful in our patient settings. Well, coming to this meta-analysis which published in 2020, here he tried to see in both high risk and low risk patient. What he found is in high risk patient, still Thymo is better compared to Il2 receptor antagonists. Well, whether to reduce the Thymoglobulin dose, I found only one study, whether to say when less than 6 and more than 6. What the conclusion was, they say even in high risk patient, there was no difference in graft survival, infectious disease or hematological problem between the two groups. To better to use a lower dose Thymoglobulin come to less than 6 milligram per kg, especially to prevent acute AMR and DGF in high risk patients. To summarize my talk, well, where we stand now, we have to individualize the induction agent. The use of induction therapy is now almost routine after kidney transplantation. You assess the risk stratification based on your center profile. Well, with the present era of triple maintenance therapy, that is the TAC, MMF, and steroid, we should remember that adding an induction may achieve an absolute reduction by 1 to 4%. In the era of cyclosporin and AZA, it was around 50%. At that time, when we use an induction therapy, it used to bring down to almost lesser. Whereas with the TAC and MMF, the actual rejection rate of acute rejection has come down from 15 to almost 15%. So we should be careful when we are choosing the induction agent based on the risk stratification. To simplify, in a low risk, you have now Basiliximab or low dose ATG, or you may not use any induction if you depending upon the patient profile. In a high risk, preferable to use a Thymoglobulin or Grafalon. So this is a table in this good article that is in 2006, where they say immunological risk assessment. To simplify, in induction wise, low or moderate risk, still Il2 receptor antagonist, higher risk T-cell depleting antibody. If you want to avoid steroid, preferable to use T-cell depleting antibody as an induction agent. In desensitization, ABO incompatible, especially when we are now using Rituximab, IVIG or plasmapheresis, it's your choice whether to use a T-cell depleting or the Basiliximab, but still preferable is T-cell depleting antibody. When sensitized patient, it's better to use T-cell depleting antibody. With this, I thank you for this opportunity.
Thank you so much. Thank you so much, Dr. Shankar. That was an excellent coverage of induction in kidney transplantation. There is one question from Dr. Bala. What about induction in spousal transplant? Dr. Shankar, there is a question for you. What about induction in spousal transplants?
Yes, sir. It means it's purely you have to see the other risk factors. Now you should not worry much about whether to use Basiliximab or Thymoglobulin. It's optional, I can say. Based on the other risk profile of the patient and how the patient is, you can decide one of the agents. There is nothing like you have to use Thymo or you should not use Thymo.
So I would add to this that in spousal transplants, particularly when it is from husband to wife, would you have any preference for a particular induction agent? Because in a wife who has conceived, who has had pregnancies, when it is from husband to wife, one would consider
Yes,
to
sir.
be a moderate to high risk.
I had understood, sir. Now, that's what I told. Means basically we have to look for the other risk profiles accordingly, like multiple pregnancies there, and as you told, husband to wife. At that time, you can go preferable to use a Thymoglobulin than that of an Basiliximab, sir.
There is another question that have you come across risk of bleeding tendency with Grafalon? Have you seen any bleeding tendency with Grafalon? That's a question on the chat box. You'll have to unmute yourself. Shankar, you'll have to unmute yourself.
Hello, sir. Sir. No, I have not come across, sir.
Okay, okay. Fine. I think you have answered most of the things in your presentation itself. We will now move on to the next part, that you have done a successful induction immunosuppression. What should be the maintenance immunosuppression now? So let me upload my slides. So I'm going to talk about maintenance immunosuppression after kidney transplant. We have come a long way from the time that we could think of doing a transplant, a xenotransplant, and that thought process was very important, because it is this thought process that has brought us today to the stage where we are. So the first successful transplant, which was a kidney transplant, became successful because it was between identical twins. And this was at a time when we had not understood immunology completely, and we did not have immunosuppressive drugs that we have today. We have come a long way since then. And with this background, what I plan to do in my presentation is tell you about the drugs available for maintenance immunosuppression today. What is the maintenance immunosuppression commonly used in clinical practice, and how should we modify this maintenance immunosuppression in different situations? So today we have following drugs available for maintenance immunosuppression. Steroids are an extremely important component of maintenance immunosuppression. Calcineurin inhibitors, cyclosporin, and now tacrolimus. In fact, now a large majority uses tacrolimus. Then we have mTOR inhibitors, sirolimus and everolimus. And again, a large majority now tend to use everolimus for ease of use. We have inhibitors of purine synthesis, mycophenolate and azathioprine, and belatacept, which blocks co-stimulation. It's not available in India, so I'm not going to talk much about it. But the most important thing is that we have to balance our immunosuppression. And this should be so balanced that on one hand, we prevent acute rejection, and on other hand, we do not cause any drug toxicity or infections and malignancies as a result of immunosuppression. So this balancing act is extremely important in determining the outcome of kidney transplant. Now, this is the site of action of various immunosuppressive drugs. You have steroids which act at various levels. They block the binding of the antigen presenting cell to the CD4 positive T cell receptor. And then after the antigen is presented and recognized by the CD4 positive cell, you have activation of calcineurin. This is inhibited by cyclosporin and tacrolimus. Thereafter, again, within the cytoplasm, the steroids act to prevent the release of various cytokines. After the transcription of gene for interleukin-2, it binds to interleukin-2 receptor, and this leads to further activation of the T cell, which is where sirolimus and everolimus act. And then you have antimetabolites which interfere with the mitosis. So these are the various steps at which we use different drugs. As I said, steroids prevent all phases of T cell activation. This is the cell cycle which shows all phases of T cell activation, and they block cytokine gene expression. But when used in high doses, they are associated with several complications. In low doses, these complications are acceptable, and it significantly reduces the risk of rejection. We all know about weight gain and diabetes and hypertension, osteoporosis and avascular necrosis, cataract, increased risk of infections, and changes in mood and behavior. The drugs which really change the outcome of transplantation are calcineurin inhibitors. Cyclosporin is a small polypeptide of fungal origin. It binds to cyclophilin, and this complex inhibits calcineurin, and it blocks the gene transcription for interleukin-2. The other calcineurin inhibitor is tacrolimus, which is a macrolide antibiotic. It binds to tacrolimus binding protein, and this complex inhibits calcineurin and prevents transcription of gene for interleukin-2. These calcineurin inhibitors are metabolized by cytochrome P450, and the level depends highly on other medications which affect P450 activity. The inhibitors increase the level of CNI, so diltiazem, ketoconazole or fluconazole, erythromycin, and cimetidine, they are supposed to increase the levels. On the other end, inducers of P450 like rifampicin INH, phenytoin, carbamazepine, and phenobarbital are supposed to reduce the dose of calcineurin inhibitors. And this knowledge is important because when you use these drugs, it can precipitate CNI toxicity, and when you use these drugs, they can precipitate rejection. It's important to follow the drug levels closely, particularly when you use a new drug, C2 level for cyclosporine and trough level for tacrolimus, because these drugs are inherently nephrotoxic due to vasoconstrictive properties. The common complications that we see: hyperkalemia, hyperlipidemia, tremors, diabetogenesis, which is more with tacrolimus, gingival hyperplasia, and nephrotoxicity. But one toxicity which is not commonly mentioned in the literature is neurotoxicity. And I would like to present to you an example of a case where there was a neurotoxicity due to tacrolimus. This was a 52-year-old male with end-stage renal disease due to diabetic kidney disease who underwent a living-related donor renal transplant with sibling donor. Surgery was uneventful with immediate allograft function and creatinine dropping to 1 milligram by day 2. Induction agent used was anti-Thymoglobaline and methylprednisolone. The standard maintenance immunosuppression tacrolimus and mycophenolate was used. And by post-operative day 3, his tacrolimus trough level was 18.4 and tacrolimus dose was reduced. On the 6th post-operative day, patient became restless, developed abnormal limb movement, and started self-muttering. There was no focal deficit, no hemodynamic instability. Electrolytes were normal, no other metabolic cause of encephalopathy was seen. And this is when we thought of tacrolimus toxicity. We withdrew tacrolimus and all the symptoms resolved, and he was changed from tacrolimus to cyclosporine. I would like to play this video for a short time to show you that what was the type of toxicity we saw. So he would keep talking to himself and muttering to himself at involuntary movements of the hands. We excluded all the causes and we thought TAC was responsible, and accordingly we discontinued TAC and put him on cyclosporine and everything resolved. We come to the next class, for proliferation signal inhibitors. This inhibits the growth cycle at G1 and S phase by inhibiting mammalian target of rapamycin. They reduce cytokine-dependent cellular proliferation at G1 to S phase of cell division cycle. The advantages are they do not have the nephrotoxicity of CNIs. They do not significantly increase the risk of infection. They have a favorable cardiovascular profile, and they have an anti-tumor activity. And I'm sure Dr. Bahadur will cover this in his talk. Everolimus has an advantage over sirolimus in that it can be given as a single dose. You don't need to give a loading dose, and it can be given concomitant with cyclosporine, unlike sirolimus where you have to give it 4 hours post cyclosporine. Everolimus, more convenient dosing, can be given with Numeral or cyclosporine. It has a better bioavailability, less nephrotoxic, lower incidence of wound healing, and lower incidence of viral infections. So this was a study which looked at everolimus with reduced calcineurin inhibitor exposure in renal transplantation. There were 2,037 de novo kidney transplant patients randomized into 2 groups. One was everolimus with reduced dose of cyclosporin, and other was mycophenolate with standard exposure cyclosporin. 1,022 patients in everolimus group and 1,015 in the mycophenolate group. Biopsy-proven acute rejection were seen in similar percentage of cases. De novo antibody incidence at 12 months was not different, but the viral infections were significantly less with everolimus. So in kidney transplant recipients with mild to moderate immunological risk, everolimus was not inferior to mycophenolate in the endpoint assessing immunosuppressive efficacy and preservation of graft function. Common drug interactions, again, ketoconazole, cyclosporin increases the level, verapamil and erythromycin also increase the level. And you do need to adjust according to the drug levels. Our experience, we have used in more than 100 cases, but it has been after 3 months, conversion has been after 3 months, where we replace TAC or MMF. Replacement of TAC if creatinine high or worsening without rejection on biopsy. Replacement of MMF if persistent leukopenia, and replacing both TAC and MMF if there is BK virus nephropathy. In those with good renal function, patients tend to remain stable. In those with chronic allograft nephropathy and creeping creatinine, after an initial improvement, there is a progressive worsening of graft function, and it's useful in viral infections. So this is an example of a patient who stabilized after transplant at a creatinine of 1.5. Creatinine rose to 2.5. Biopsy was unremarkable. He again had a rise in creatinine after reduced dose of tacrolimus. Again, a biopsy was unremarkable. He was started on everolimus, tacrolimus was discontinued, and he is now stabilized with a creatinine remaining around 1.6 to 1.7 milligrams per deciliter. He is stable even today after 9 years of transplant. This is an interesting case. This was a lady who had a living-related donor transplant, and about 8 months after transplant, she presented with multiple warts in both the fingers of the hands. This was on 6th Jan 2018, and at this point in time, mycophenolate was withdrawn, tacrolimus was replaced with everolimus, and you can see complete resolution on, this was on 30th October 2017, this was on 6th June 2018, this was on 2nd December, and by 5th February, there was complete resolution of all the warts. Side effects, delayed wound healing, and therefore we never use it in the early period after transplant. Oral ulcers, hyperlipidemia. We don't see that much with myelosuppression. Edema is a common symptom. Proteinuria, chemical pneumonitis. And this is an example that I would show. One 28-year-old male underwent living-related donor transplant, and his maintenance immunosuppression was TAC, MMF, and prednisolone. 17 months post-transplant, TAC was stopped for tremors and replaced by everolimus. 1 month after conversion, he complained of fever with cough. Treated empirically with augmentin, did not improve, developed breathlessness, and was admitted. On admission, was found to have low-grade fever. All workup done for fever and cough was unremarkable. His CT chest showed bilateral patchy pneumonitis. And this was the CT chest showing bilateral patchy pneumonitis. This is how he had fever. His everolimus was stopped. His cough settled and his fever settled. We now come to mycophenolate. Mycophenolate is in one form a selective immunosuppression. It acts at the level where it inhibits inosine monophosphate dehydrogenase. Now we have two pathways of purine synthesis, de novo pathway and you have a salvage pathway. So mycophenolate blocks the de novo pathway, but the salvage pathway can still be used for purine synthesis. The lymphocytes depend on de novo pathway for purine synthesis. In that respect, mycophenolate is a selective immunosuppression. It's a promising agent, and now, because of its potent immunosuppressive activity, mycophenolate has replaced azathioprine as a maintenance immunosuppressive drug, but it is associated with some side effects like epigastric discomfort, loose motions, leukopenia, and opportunistic infections. One of the common complications that we see with mycophenolate is diarrhea, which can completely resolve by discontinuing mycophenolate. And one should not be worried about rejection when diarrhea becomes very discomforting and distressing. Yes, one can change over to proliferation signal inhibitor in case one is worried about rejection. So here is a 45-year-old female. She had a transplant in 2009 and she was on standard maintenance immunosuppression. In February 13, her creatinine rose to 1.7 and biopsy showed CNI toxicity, so she was changed to sirolimus. In October 13, she presented with 3 months history of diarrhea, 8 kg weight loss, and creatinine increasing to 2.9. So we stopped her sirolimus. We also stopped the mycophenolate and put her on azathioprine because father was the donor. She was 5 years down the line, and we thought that she should be okay with minimal immunosuppression. In 6 weeks, her diarrhea stopped, she gained weight, and her creatinine stabilized at 2.1 milligram per deciliter. So if you have persistent diarrhea, it is important to keep mycophenolate in mind. And if you are worried about precipitating rejection after stopping mycophenolate, you could add proliferation signal inhibitor if the kidney function is decent. Azathioprine is still a very good drug. It is used for more than 50 years in transplant. It's a purine analog that interferes with purine nucleotide synthesis. It suppresses all rapidly proliferating cells, not routinely used, but we do switch over to azathioprine in cases where mycophenolate is not tolerated. Side effects are hematologic and rarely it causes hepatitis. We had one such case recently. Belatacept is a selective co-stimulant blocker. In the setting of antigen recognition, signal 1, blockade of signal 2 inhibits T cell activation, promotes energy and apoptosis, but it's not available, so I'm not going to talk more about this. And now talk to maintenance immunosuppression in clinical practice. So there was a randomized trial which looked at different immunosuppressive regimes, and they looked at 3 different combinations. And in those 3 combinations, tacrolimus MMF was more favorable than tacrolimus, sirolimus, or cyclosporine and sirolimus. So today, tacrolimus, mycophenolate, and steroid is the most commonly used maintenance immunosuppression. One option is to use steroid-free or steroid in low doses. So this was a study which looked at 100 patients, ATG induction and maintenance immunosuppression with just cyclosporine and mycophenolate. The acute rejection rates were low and 1-year graft survival was excellent. So in low risk cases, one can consider steroid-free immunosuppression. In our experience, we have used it in 27 selected patients, low immunological risk, children in growth phase, elderly and diabetic. Induction immunosuppression was used in 64% of the cases, and in 35% where it was very low risk, no induction agent was used. Steroids were used for first 5 days and then abruptly stopped. Maintenance immunosuppression consisted of TAC and MMF for azathioprine. The mean age was 45 years. Out of 96% who were hypertensive before transplant, only 15% remained hypertensive post-transplant. Only 7% developed no new onset diabetes after transplant. 11% had acute rejection, and infectious complications were low and seen in only 15% of cases. How do we modify maintenance immunosuppression in different situations? If you have CNI toxicity, withdraw or replace with proliferation signal inhibitor. If you have leukopenia, withdraw or reduce MMF or azathioprine. If you have epigastric discomfort and diarrhea, withdraw MMF and replace with azathioprine. And you could add a PSI. With BKV nephropathy, withdraw MMF, reduce CNI or replace with PSI. And if you have PTLD or post-transplant lymphoproliferative disorder, reduction of immunosuppression is the key thing. Withdraw MMF, reduce CNI or replace with PSI. So I'll give you an example of a 36-year-old male with end-stage renal disease. He underwent an ABO-compatible transplant with his HLA-matched brother. Being full match, no induction was used. Maintenance immunosuppression was steroid-free. He was only on TAC and MMF, and he stabilized at creatinine 1 milligram per deciliter. This was November 2018. He remained stable until February, when he presented with swelling on the left side of the neck. We thought it would be TB, but it turned out to be post-transplant lymphoproliferative disorder. It was a diffuse large B-cell lymphoma. MMF was withdrawn and TAC was replaced with everolimus, and we observed him, but his swelling persisted. So we then treated him with 2 cycles of Rituximab. And you can see over here his initial presentation. After biopsy and reduction of immunosuppression, he still continued to have swelling. In fact, the swelling grew, and therefore we gave 2 cycles of Rituximab, and now there is a complete resolution of his lymphoma. So in summary, maintenance immunosuppression is important to prevent rejection, but it should be individualized based on recipient's immunologic risk and comorbidities. And this will be talked about more by Dr. Vikas tomorrow, when he's going to talk about selecting immunosuppression based on efficacy and morbidity. The most commonly used maintenance immunosuppression is TAC, MMF, and steroids, and maintenance immunosuppression must be modified in different situations. I would like to acknowledge my transplant team, and it is this teamwork and the transplant immunology evaluation and monitoring that we have now introduced in monitoring of transplant patients that has significantly helped improve the management of our transplant patients. Thank you very much. I think there are some questions, so let me see if I can answer that. Weight gain with mTORs, no, I have not seen weight gain. But yes, BOOP on mTORs, I don't know whether it is BOOP or hypersensitivity pneumonitis. As I said, we do see this. Choice of maintenance immunosuppression in AD-PKD, it is still the standard immunosuppression. Even for spousal transplant, our immunosuppression is still TAC mycophenolate, unless we see a problem with this. How to do monitoring of long-term immunosuppression? Cell-free DNA is extremely expensive. It's not easily available. We are not doing gene expression. DSA monitoring is important, and we do it in our transplant patients. So that completes all the questions. I would now like to introduce Dr. Madan Bahadur. who is Chief of Nephrology and Transplant at Jastrow Hospital. He also offers his services at Wokat Hospital. He is the one who was a part of multi-center study which looked at de novo everolimus, and I can't think of anyone who can be better than him in telling us about use of everolimus in kidney transplant. So over to you, Madan.
Thank you, sir. So, as was, may I start my sharing? Okay. Right. Okay, so Dr. Bharat Shah has told me right at the beginning of our presentations that we would like to have this in a practical way. And so what I thought, and as he has suggested, I would become a little personal on this. So de novo usage of mTOR. Is it old wine in a new bottle? That is what the question is. Everolimus, old wine in a new bottle. Well, we had this everolimus back in 2004. And at that time, let me go back, journey back in time 17 years ago. And so I went back and took out my slide set of presentation, which I did 17 years ago. And so what has changed? That the question was, what has changed? So let me put it on my, okay, right. So what has changed in the 17 years? And why did everolimus didn't catch up over the time? Let me see, I can't see myself. So if I can just look at that.
So we can see you.
Okay, fine, that's fine then. Okay, so the thing is a journey back in time 17 years ago and a slide set which I showed at Mumbai, Calcutta, Bangalore, and Nagpur. And so we start from there. De novo everolimus, the Jastrow Hospital experience. And we actually went on to do 68 de novo transplants. This was presented in 2005 and 2006 at all these places. And of course, the slide set was like this. It showed Pascal comparing cyclosporin era with azathioprine era. And look at this. The first year, second year was very good. But at 15 years, it did not matter. It did not matter whether you had a CNI to start with or you did not have a CNI. Have things changed? We'll come to know the answer is no. So the short-term survival, the early rejection, the acute rejections have been beautifully controlled with CNI and the other drugs. But we are still at a loss to increase our 15-year graft survival to respectable levels. And so this was a slide which was shown back in 2004. And then this was the slide which we used to show that, Nankivell. Now this was a very classic slide which showed that to improve long-term function, what were the main cause? And it was all blamed to CNIs. So what it showed was at 1 year, you could already see 94% of grade 1 CNI toxicity. And at 5 years, it was 100%. And look at that. Striped fibrosis at 10 years was 87%. And so the pendulum was on this side, that the fall guy was CNIs. And so we need to get the CNI out. And at that time appeared mTOR. And so the experiments in de novo everolimus started, and I was very much part of it, though not part of any study at that time. We did it at Just Look on our own. And so what happened? The overview of benefits of everolimus has already been shown. Inhibits T cell proliferation, prevents rejection. Incidence of allograft vasculopathy is reduced, is less nephrotoxic, enables reduction of CNI dose, has lower nephrotoxicity as compared with full exposure CNI, and is associated with lower incidence of CMV infection versus MMF. So this was very well known even in 2005. And the question is, then why didn't it catch up? And that is what we will know. We did about 68 transplants from 2005 to 2006. And this is the same slide set I am representing this time. Out of this, at that time, there were de novo 27 and conversion 10. So almost at that time, 37 transplants. The conversion was within 10 or 14 days. And of course, how did we do it? We had a C2 targeted cyclosporin dose reduction and everolimus level targeted giving of everolimus and a rapid taper of steroids to 14th day. So the de novo patient was everolimus day -2. This was all day -2. Everolimus, steroids, and cyclosporin. And for the cyclosporin dose, at that time, we started at 8 milligrams, reduced to 7 milligrams after 2 days, and subsequently, as per C2 monitoring. Average dose was 5.5 by day 14, and dose after 3 months was 1.1 to 3 milligrams per kg, average being 2.3. And subsequent dose changes, we came to know, actually did not affect C2 levels significantly. The other thing, of course, we very well know that cyclosporin shoots certican level by at least 40%. And that is why, to make it more cost efficient, and because that was the only known criteria at that time, cyclosporin, there was no significant TAC at that time. So in 2005, it was cyclosporin all the way. And Rituximab, because ATG also was not the done thing at that time and was frequently not available. Everolimus doses initiated at 1.5 milligrams, not 3. Level at day 3, dose adjusted to keep a range of 3 to 8 nanograms. Dose required to meet target levels achieved was 0.5 to 1.75. Again, very cost effective. And most patients at that time were about on 1.25 milligram per day. Now, reasons for discontinuation. And that was the thing which really bugged us, and the reason why basically this drug did not catch up as a de novo initially. Looked at that lymphocyl, hydrocele, prolonged drain in 7 cases, rejection only 1. And rest, of course, severe anemia, life-threatening pneumonia, loss to follow-up or cost. So close to 45% of my de novo patients, we had to switch. And we showed in another slide that it did not matter because the creatinine of those that we switched also remained 1.3 to 1.4, not as good as those that continued with everolimus. And then there were other complications, bacterial, acneiform rash, limb edema, avascular necrosis, and dyslipidemia requiring statins, which are very well-known complications of an Alemtizumab. So lessons learned at that time was, when we use everolimus as de novo, acute rejection is actually not a major problem if used in the context of a lower cyclosporin dose. So we could aim at a lower cyclosporin dose, and that really was thought to help in long-term graft survival and graft GFR. And we could titrate everolimus not to 8 to 12, which was being done for CNI-free protocols, but just to 3 to 5 nanograms. And out of the patients who received IL2 induction at that time, that was 7 out of 27, None of them we had to take off because we could achieve lower C2 and maintain them on a lower C2 level. Average creatinine of all these patients at the time of presentation at 1 year was 1.3 milligram% with a creat clearance, which was excellent. And so at that time, what we said, so which patient for everolimus, because the problem was almost 40% withdrawal or change of this particular thing. So old for old transplants, yes. Young patients who would require long immunosuppression over the years, yes. De novo patients at high risk of suboptimal renal function, yes. And patients at risk for CMV, which we found that CMV infection was very low. And in the maintenance setting, patient at risk for exhibiting CNI-related toxicity or CAN, or those that exhibited a CNI sensitivity early on. And so, but you look at what the target from the studies were. At that 2306, that was the Certican study initially, when we were using 1.5 milligram without induction, a C2 level desirable in the first month was 1000 to 1200. That's important. And a C0 level, something like 220 to 275. And in 2307, the next study in which it was mandatory to use an induction, we could target a C2 level of 700, which would translate to something like 100, 150 of C0 in the first 2 months. And the one which actually did give pretty good results as a de novo induction studies. So the whole idea today is, as we move to 2021, is that I'm going to focus on one study which has really transformed the use of everolimus in the de novo setting. And what is it? I am quite fired about reusing everolimus once again after stopping it for close to 5 to 7 years. We know that converting after 6 months in the convert trial is not a good idea. So when to convert was a big story. We also know that not using CNI is not a good idea. So taking off the CNI completely is not a good idea. Starting without a CNI is also not a good idea. Converting late is also not a good idea. So starting de novo or at 14 days, it's not a bad idea. But we had all those problems, and have those problems been resolved? So status of outcome now. We have had advances in surgery, immunosuppressive regimens, monitoring, and we have still better 1-year survival rates of 97% living graft donors and 90% of diseased graft donors. And acute rejection rates 5 to 7%, very low. So no. However, there has again been little or no improvement in long-term outcomes. At 5 years, 25% will return to dialysis. At 10 years, around 50% will be back there. So the question is, we are where we were at 2017, and we thought we need to do something. And so again, it's time for us to do something if it is a little better than what it was before. So this transform study design, look at that. So first change is this: almost all of them had induction. So whether it was Basiluximab or whether it was ATG, more of ATG, less of Basiluximab, all had induction. So the nephrologists were reassured to achieve lower cyclosporin level and now tacrolimus level. So at that time, that was not the done thing. You know, the TAC had just come in, and TAC MMF steroid was the standard thing. And we were trying to compare cyclosporin and everolimus against reduced cyclosporin against a standard cyclosporin. But that was not the done thing. Now, we also had to show that using TAC and MMF and steroid in the standard dose would be comparable after using what is being used today. ATG, as we have seen in the previous lectures, the use has gone up. The Rituximab use at present is on the lower side. And yet, when we just replace one thing, MMF with everolimus, and reduce the either TAC or MMF, how do we do against a standard protocol that Dr. Bharat Shah has just told us in maintenance? So the change was you could use either cyclosporin or TAC. So that's a big deal. Almost all patients received induction, including ATG. And this was compared with the standard protocols of MPA, standard CNI, and steroids. So whether it was TAC in the first month at 8 to 12 or cyclosporin C0 of 200 to 300, this was against a C0 of 100 to 150 and a TAC of 4 to 7 in the first few days. So that's important. And at the second month, TAC had come down to 2 to 5 and C0 had come to 50 to 100. And at 6 months, the C0 was down to 25 to 50, targeting the lower number, 25 or 50 or 100. And here, again, the tacrolimus targeted to something between 2 and 4. And then, of course, this was the standard that we use. We keep in the standard tacrolimus 6 to 10 and a cyclosporin of 150 to 200 and then 100 to 200, depending when we are talking about. And maybe down 6 months, we like to keep the TAC to 5 to 8. So now this was real life comparison. This was not a comparison only meant to prove a point for a particular company. It was real life comparison of how we do transplants today. And then what did we find? It incidentally is the largest trial to date, 2,000 de novo kidney transplant patients, 186 centers, 42 countries. And there is a subset analysis with Asian. So that including about 39 patients from India. So this was a very well spread transform study, and it compared a real life alternative standard to something which is explorative, and everolimus, which is back after about 15 years in a different form. And so what did we find? We know that the major cause of graft failure beyond first year is CAN. Okay, so one of the major reasons for CAN, we say still, is CNI. But over the years, we know that chronic antibody mediated rejection, as Shruti had pointed out in the first lecture, is actually the bigger problem. And so we would like to see what happened when we compared to de novo DSAs. And that is very important because this is a real life problem. And we know that CNI toxicity is only a part of the problem. Maybe a major problem is chronic antibody mediated rejection. And then, of course, death with a functioning graft. And how does it work? So factors contributing to CAN, as we have already talked about. And so 40% of the patients, around 50% of deaths of transplant patients happen with a functioning graft. And that is a big deal. So now we are not focusing only on CNI toxicity reduction. We also want to know whether the patient lives, because the graft will live only if the patient lives. And we find Forget the graft. 50% of recipients will die with a functioning graft because of cardiovascular disease, malignancies, and infection. mTORs as has been discussed with Dr. Bharat Shah, cardiovascular disc, vasculopathy, malignancy, these are big things. When we are dealing, any big center who has been around for the last 25 to 50 years will know that these are the things that matter when we talk about long-term survival of the patient and the graft. And so, besides acting on the graft, we have subsidiary benefits which come with mTOR if it actually came through. So we will look at that. So, though CNI represents a cornerstone in maintenance therapy of immunosuppression, they partly contribute to a poor long-term outcome. Thus, a key challenge was, as in 2014, 2005, to develop immunosuppressive strategies allowing reduction in exposure to CNI, leading to reduction in CNI-related adverse events, while maintaining current low acute rejection rates and also reducing the side effect profile of everolimus. That was the challenge. So de novo minimization was the strategy to go forward, because with various trials that followed, which I am not going to go into, the Caesar trial and others, the biopsy-related acute rejections were almost comparable with reduced CNI to standard CNI. So it was a feasible possibility. And so can de novo use minimize the CNI utilization? And as we know, and as we have said, besides reduction in CAN, cardiovascular benefits, antiviral properties, big deal today with the use of ATG. ATG has its benefit, ATG has its problems. When we are not using ATG, CMV and BKV were hardly there. Last 10 years, they have become a rage. Almost 8 to 10% would come down with a CMV or BKV. So this drug also has antiviral properties, anti-malignancy effects, of course, cannot be discounted. So how do we go about this? We could use everolimus at 1.5 or 3, and the final thing was that 1.5 milligrams per day was a good idea. Then, of course, we were using it against MMF, and we could use it against standard CSA or low CSA. But this slide just showed that by using everolimus, whether we use 1.5 or 3, we were able to reduce CNI levels by 60%. So this study, not part of Transform, actually showed it is possible to reduce the CNI level and still not have acute rejection if we use everolimus instead of MMF. So, to evaluate the efficacy safety of de novo everolimus with standard CNIs, including tacrolimus, which form the major numbers rather than cyclosporin. Design we have just discussed. How did it matter on biopsy-proved acute rejection? Now, this is important. The blue is everolimus plus reduced CNI, and the gray is the standard CNI and MMF. And standard CNI includes a majority with TAC, also with cyclosporin. Real life situations. And look at this. So at 12 months, no difference, a little better. And at 24 months, no difference, a little better. As far as statistics is concerned, no difference. So everolimus with the reduced CNI regimen maintained anti-rejection efficacy, preserving renal function, similar to standard dose regimens at both 12 and 24 months. So first thing, the fear that we could have more rejections, which of course we didn't have because we had used it earlier, is not correct. We have comparable or a little lesser one or more, not statistically significant. What about mean GFR? Everolimus and CNI regimen, reduced CNI, significantly better renal function at 24 months, 72 against 66. And I showed you in my own experience, our GFR at 1 year was 75 at an average. And so better, this was significant. There's a p-value of 0.05. So with equal rejections, better achieving of GFRs or renal function. So graft, when you add up biopsy-proved rejection, graft loss as compared to the two things, again, at 24 months or 12 months, it did not matter. So here, biopsy-proved rejections, graft loss or death, the hard points, none of them actually were any different from standard ones. But when you look at the effect on the CMV and BK virus, overall with the overall infection was more with the standard protocols. CMV was significantly high, BKV was significantly high, and all of those with a p-value of 0.001. So that is already a big plus point. When you have better GFRs, equal acute rejections, lesser viral infections, CMV and BKV, context is, I would blame it on ATG. But that is what the standard is today. And with that, this is a big plus, which I find. And this was the point which actually brought the downfall in between the 2005 and 6, and until we had several other such large de novo studies. Because from CNI toxicity as the major reason for a chronic allograft nephropathy, the pendulum swung to chronic antibody-mediated rejections. And lo and behold, if you look at this, incidence of de novo DSA with everolimus and CNI is much lesser than with the standard one at 24 months. So the one point which was held against this particular regimen also, it scores better with de novo DSA. And so the key findings were the 2-year follow-up, comparable anti-rejection efficacy, significantly better renal function, and this was also shown in Asian population as a subset analysis via reduced CNI exposure, additional benefits of overall mortality, which was lesser viral infections of CMV and BKV, and a de novo DSA, which was lower with everolimus and reduced CNI. So last 10 patients in last 2 years as de novo, what have been my indications? So once we are become more confident with this transform study, and now that we are comparing the actual standard maintenance and induction protocol of induction and the early on all the three maintenance. So induction, ATG/Rituximab, TAC, MMF, steroid, or cyclosporin, MMF or steroid. actuals. And when we have found that it is scoring on the GFR front with lesser equal rejections and also on the viral front and the malignancy, I have started using this more often. At present, not as a routine, but much more often than I would have done. And when in the face of ATG, wherein we can target much lower levels or Basiliximab, I have found that all those reasons which were primarily due to delayed graft healing do not appear this time. And almost none of these last 10 patients, I have to take out the everolimus from my protocol. So the present indications for me are low nephron mass transplanted. So if you have a GFR of 33 or 32, which you have transplanted, I will do that. HUS as possible of proved native disease, where I would not be very happy using TAC. So that is one of those. Or in the immediate post-transplant, I have done a biopsy in the 3rd day, 4th day in a suboptimal graft, and it is showing changes of HUS. Well, immediately TAC is off. Either he or she is either only on everolimus, MMF, steroid with an induction, or cyclosporin, everolimus, and steroid. TAC-induced HUS. Then, of course, all those who practice transplant know certain patients are very CNI sensitive. They not be toxic. It may actually not show on your biopsy, but yes, every time you give your TAC, after 2 hours, the urine output comes down. These are much more CNI toxic. So toxic or sensitive, leading to delayed or suboptimal graft function. That's another indication for me. Of course, CMV or BK virus disease, definitely. A patient, a recipient with cured malignancy. Oh yes, that is one. And post-cadaveric delayed graft function, when I'm not sure how much CNI is contributing to delayed graft function. So actually Transform has transformed everolimus into a safe, predictable de novo drug in today's context. That is the important thing. And so, despite advances in acute rejection and 1-year graft survival, long-term graft survival remains poor. Major cause, one of the major cause is CNI in higher doses, maintained for longer periods, wherein CNI minimization with de novo usage of everolimus addresses challenges associated with CNI and improved long-term outcomes. You may ask why you have to use it at de novo. The answer is you will never use it if you have not used it de novo, because we know whatever damage has to happen happens in the first 6 months. If you start with a graft which does not have a good GFR, mTOR is not the drug for it. So to start CNI, to start minimizing CNI, you have to do right at the start or during hospitalization, maybe within 14 days, or de novo like we did, day -2. And so de novo and everolimus not only manages the risk of acute allograft rejections, but also has potential to improve long-term outcomes. We'll see how it happens. What about those patients out of those 28 that I've talked about in my 2005, who actually continued on? They have done wonderful as far as graft outcomes are concerned. That I can assure you. So associated with improved, so if we don't have to take them off, I am sure about it. The graft outcomes, long-term graft outcomes, which is about now 16 years, is very good. So associated with better renal outcomes, reduction CMV, BKV, anti-malignancy, and cardiovascular benefits. I am not sure about how much it translates into cardiovascular, because 2 of these long-term patients actually required an angioplasty. So Everolimus, is it old wine in new bottle coming this time? Or this wine has matured? Or we have matured? Whatever it is, we now know how to drink or maybe use it de novo. So it's already 9 o'clock plus. Cheers to you. Thank you. So
Thank you, Madan. There are some questions. One is from Dr. Ganesh Prasad. Any limb vascular insufficiency with use of everolimus? Have you seen?
So I can tell you serious and severe limb edema I have had. But if I show you some of these patients, one or two of my patients, almost like elephantiasis. So, but if you're talking about vascular insufficiency, none, no.
So in cases who develop severe limb edema, like elephantiasis, what do you do?
So that is a good question. This is one or two patients of mine who were there. And we did show to our, of course, we tried everything. We tried to reduce and then we showed it to plastic surgeon, whether they could do a roll on. Finally, the patient decided that he or she wanted to preserve the graft rather than really trying to do that. But that limb edema of all these patients is only one, which was severe and which is persisting. So really, I couldn't do much about it. No.
There is another question from Ganesh Prasad that did you use everolimus when CNI levels were erratic or there was TAC-induced severe hyperglycemia?
No, I'm talking about a de novo one. But yes, in our practice, just to treat TAC-induced hyperglycemia, I have not shifted a patient to mTOR because generally we are able to manage these patients. Just for hyperglycemia, no, I have not done that. I could have changed to cyclosporin, but not because of hyperglycemia. But for other reasons, as I've said, TAC sensitivity, TAC toxicity, definitely that has been one of the major indications in the recent times. Yes. And specifically, I would again like to point out reduced nephron mass because of anything. Either we have transplanted, with a little impaired one, or suppose we have done a biopsy and there has been a bleed and I have used a gel when maybe 15% of the kidney has knocked out. This patient I've shifted and such a similar, or if this patient had 3 vessels and one with the inferior epigastric or one of the upper polar branches actually, popped off. And now we are left with about 80% of the kidney. One of this patient, 2005, still continuing today, who we lost 20% of the kidney at that time, maintains a creatinine of 1.4. So not only at that time, I am talking this time, I am more using it liberally if I have a reduced nephron mass and my creatinine is not coming to my expectations.
There is a question from Dr. Prashant Rajput. Everolimus causing acute arterial thrombosis. Is it? Have you seen that?
Somehow I have not seen that. No, sorry. I have not seen, maybe, but I have not seen that.
And what do you do for those who develop mouth ulcers on everolimus?
Yeah, it's a really difficult one because nowadays, if I'm using it with a reduced CNI, the mouth ulcers have not been a problem. But when we use 2, in which I am using no CNI, means suppose TAC-induced HUS was there, or HUS has come as a primary disease, in which I have used everolimus along with MMF. That is a big trouble because if you have 2 anti-proliferative, this is a problem of oral ulcers. So we have tried to balance, reduce the dose, of course, and try to work with that. But none of these patients, especially those with reduced CNI, I have had to take it off or discontinue the drug because of oral ulcers.
If you see the Transform study, while there was a benefit as regards low incidence of viral infections, the percentage or the number of patients dropping out were more in the everolimus group than in the standard immunosuppression group.
Right. But I don't think it actually became significant, this thing. It did not become statistically significant. And practically, I can tell you, this time when I'm using everolimus with an induction agent and with lesser doses, these last 10 patients, I have been able to continue them. And they are doing pretty, well, it's a different experience than what I had earlier.
So, in your opinion, is everolimus as potent an immunosuppressant as CNI, or you think it is slightly weaker?
No, it is. It has to be used with a CNI. I am very clear on that. Very rarely, as I said, I have been forced to use it when there was a flagrant HUS on my biopsy where it looked that I would lose the graft. That is the time when I have made him CNI free, and the patient is still doing well after 2 years. But that is an exception. I would rather use it with a CNI because definitely for a long-term maintenance of the graft, it is well established now that chronic ABMR is chronic, antibody-mediated rejection it supersedes the CNI toxicity. So we need to have a CNI in the system, definitely.
So when you, there's a question in the chat box, how do you monitor the drug level? And what is the trough level to maintain in the post-transplant period?
Right. So in the immediate, whenever we start everolimus, and I said we started day -2, or whenever we started a little later, if it is a replacement, then we do a drug level on the day 4. That is important for everolimus. And C0, if it is cyclosporin and TAC, that's okay. And as is being done more and more with liver transplants, sometimes we use a combo of everolimus level to a TAC level, which should be around 8 to 9, 8 to 10, a combination of the two, because finally both are on. The only thing is, of course, when we use TAC and everolimus, my dose for induction would be 3 milligrams, because that's how it is. Because cyclosporin fires the everolimus level, and then if it is cyclosporin, the dose is 1.5 milligrams per day. But if it is TAC, then it is 3 milligrams to start with. Then, of course, we go by the levels.
Is your induction immunosuppression different when you use standard dose CNI versus everolimus and low dose CNI?
These days, mostly I am using low dose ATG, 1 milligram per kg as an induction generally. But Basiliximab also we have used with good results. So only for patients who are low or medium risk, the induction would be Basiliximab. Anything else, or even spousal or anything else, is 1 milligram per kg ATG.
There is one question. Any caution about use of everolimus in those who have recovered after COVID and in those with interstitial lung disease?
Yeah, see, the interstitial lung disease is it's not that interstitial lung disease will progress because of this. In fact, it is an anti-proliferative, anti-fibrotic drug. If it has to happen, it will happen in a normal lung actually. So not really, that would not count as this thing. And if you ask me whether if a patient who was in everolimus and who got COVID, that has happened to my patient on a long-term everolimus. And what we did was we took off the everolimus for a period of time, 14 to about 3 weeks, and then reintroduced in his usual doses. I actually took it off. But he's back on that.
Any more questions? Dr. Shankar, would you like to add anything? So, well, if there are no more questions, we bring today's session to an end and we take it further tomorrow. The first talk would be by Dr. Vikas, and he will talk about use of immunosuppression based on efficacy and morbidity. And I think that should be interesting. And then we will have pathology of rejection and treatment of acute and chronic rejection. Thank you all for joining.
Thank you, sir. Thank you very much from our side. Thank you.
Thank you.
Thank you,
Look
Dr.
forward to seeing you all tomorrow at the same time, 7 p.m. Thank you.
Sure. Thank you.